Right, everybody out in Etherland, are you quite happy with what you've written down so far?
I haven't done all of them yet.
That's okay, Henny. You're allowed to be not up to where everybody else is with the group because there's one of you working, alright? So don't worry about that. Just take copious notes for yourself.
Okay.
How about you and Dumfries? Are you all alright?
Yeah.
Okay, that's fine then. And as you are on the screen, could you please kick off then with the signs and symptoms that you might expect to see with somebody experiencing some sort of cardiac anomaly?
They're gonna be short of breath,
Mm-hmm.
sweating maybe,
Mm-hmm.
and also they're gonna be the color kind of like pale, grayish.
Yeah.
They might have a crushing pain in their chest, and it might go down their left arm.
Okay. That's fine, right? That's great to start off with there. So that your patient might have shortness of breath, be grey in colour, might be sweaty, and could have crushing chest pain, and you suggested that it might go down one arm. Okay. Anybody want to advance on that? Hanif, do you want to add anything to that?
I didn't do that one yet.
That's fine. That's okay, just write frantically then. Okay, what about an Inverness? Did any of you come up with anything in addition to that?
No pulse.
Okay, if they've got a full-blown arrest, there will be no pulse. But again, going back to what we spoke about last week, your action at the scene of an emergency, if you come across a patient who's not breathing, you don't look for a pulse. You just go straight on into CPR. Don't waste time looking for it. Okay, but just to go back to the points that you've raised there for the Dumfries, yes, your patient would absolutely have a feeling of a shortness of breath. They would be likely to be sweaty, and like we talked about last week about shock, what particular type of skin feeling might somebody be experiencing here? They would be clammy. Yeah, cold, clammy skin, just as we spoke about in shock. And when you think about, when we spoke about hypovolemic shock being as a reduction in the volume of circulating fluid in the blood, in the system, if the heart is not pumping effectively, well, of course they're experiencing a hypovolemic shock of type, okay? But this is a very specific incident. So, they will have cold, clammy skin, they will have shortness of breath, they will be grey, at least very white, but probably grey to look at. They could well experience a very extreme tightening in the chest. And I don't know if any of you have ever seen posters about raising awareness about heart attack, but what they will often show is a guy whose his torso is uncovered, and they've put a belt around his chest, and it's pulled so tightly. They've obviously CGI'd it. I don't think they did this to him physically. So his chest is almost sort of curved, like it would be at your waist, with the tightness of that belt. Apparently it's like some massive weight sitting in your chest, and you cannot inhale properly, or you don't feel that you can inhale properly. But it is important to note that not everybody will experience that, so don't use that as just a rule of thumb. In addition to the possibility of having radiating pain down one arm, it's much more likely that your patient will have radiating pain down both arms if they have pain at all that's radiating. It might just be chest. It won't necessarily just be one or the other arm. So again, try not to use that as a rule of thumb, thinking about, well, okay, well, you don't have that, therefore you're not having a heart attack. You're going by all the signs and symptoms here.
Do you mean both at the same time, or it could be one?
It could be one or the other, or it could be neither, or it could be both.
Okay.
It could be anything, really. Your key thing is, does your patient look like they're having a heart attack? And the answer is most definitely going to be more than likely yes. In addition to that, if they're feeling that pain, it might also be radiating up into the neck. So there could be all sorts of different places. And there are some key differences between men and women, let alone between just individuals, about what sort of symptoms that they might display. But be aware of the most common ones are that crushing pain, the greyness of colour, the shortness of breath. But one of the key symptoms, and again, if your patient's heart has stopped completely, as you were referring to there with them not having an output, they're not going to be able to tell you how they're feeling. But one thing of patients who remain conscious through an episode of an infarction like this is that they have a feeling of impending doom. Now, I love that statement. It's just so dramatic, but that's exactly what it is, and that's what's written in first aid books. The patient will feel impending doom. I don't know how you describe that. It's just that awareness that something is very, very wrong with them. And there have been situations where people, and I know of at least one person, who felt all these symptoms while driving and drove himself to hospital. But two. One of them worked at the college. One was when I was growing up, and another one just did that within the last year at the college. Anyway, drove themselves to hospital. But they had that feeling of, oh my word, something is not right, and they knew to do that, and that's at best reckless. At worst, efficient, that they got the help that they needed. But that feeling of impending doom is critical that it's acknowledged by first aiders, because anybody who's first on the scene with a patient feeling like that has an immediate role to make this person feel calm and reassured. Remember, the key things are about the speed in which you get help for somebody who is in this situation. So, draw that line back a little bit about the fact that you've come onto this situation. How do you know that this patient isn't experiencing an angina attack?
Because
I want you to say because they're not.
the symptoms can be different.
Such as? And that is a bit of a hard question, sorry. But they tend not to be that different. They will present very similarly. You will also, it has to be noted, you will also get some patients who will present with what's known as a silent heart attack, where they actually have had an infarction, but they haven't had all of those signs and symptoms. They've just felt really crap, excuse my French, really, really unwell and just not right about things. But they don't have any of the crushing chest pain, they do feel breathless, they're a bit nauseated, they're just a bit anxious, but they don't actually know what it is. And the only way of determining that they've actually had an infarction is to do what? How would you know? How is it, if I was to say, right now, one of you has just had an infarction, how would be the best way to tell? Apart from the fact you might be lying on the ground.
Check the pressure.
No, the only way you can tell is by doing bloods. The cardiac muscle gives off an enzyme after a period of ischemia. If there's been a reduction in the amount of blood to that particular tissue, the cardiac muscle releases an enzyme into the bloodstream. And it's just like a marker. So you do bloods, enzymes present in the blood, that person has had some sort of infarction that they weren't aware of. But it's, it's quite a useful follow-up for some GPs if somebody's been complaining of just not feeling right in any particular way. But with angina, the signs and symptoms can be very, very similar. They're unlikely to get to the point, as Hannah was saying, about having absolutely no output. They're unlikely to get to that bit. How are you going to know if somebody is experiencing angina? What other sign would you be looking for from them? And this is a very definite physical sign that they may have. I'll take the silence as I don't know. A medical alert button, a medical alert bracelet or a necklace is that straight. It is seriously that straightforward. They might have something like that on them that would say, yes, I actually have angina. So you're still at the situation where you've come across this patient who's complaining of chest pain, who's sweaty, cold, clammy, grey in colour, and showing you all the signs that actually we're going to be having a cardiac arrest possibly, or we're in the middle of some sort of heart attack here. You need to be able to then think, right, okay, but you do have this angina bracelet on. Now, just because they've got an angina bracelet on doesn't mean to say they're not having a heart attack, but you need to rule out one thing first. So, how would you treat that?
GTN spray.
Yeah, so if you don't have any on you, hopefully your patient will have on their person some sort of GTN spray, which is administered in what way? Yeah, sublingual. So it's literally they have to open the mouth, lift up the tongues and why? Why is it given there?
Goes into the bloodstream quicker.
Goes in really fast. Two best places you can actually give anybody medication, one is under the tongue and the other is definitely not. Okay? Most effective method of drug absorption. Rectally, sublingually, without a doubt. But you're not going to rectally with the GTN spray. So yes, spraying sublingually GTN will have what effect? How is that?
Doesn't it like loosen the blood vessels that are constricted and they can get more blood flow?
Yeah, it just opens them up. So if you've got a patient with angina, or if you've got a patient that you suspect might be having a heart attack, your treatment at that point is pretty similar. You want to sit them down, give them their GTN if they've got any. That in itself, just sitting down and taking GTN should be enough for them. It's unlikely that your patient with angina would then have to go to A&E, because it might be something that they've already had. If it was a particularly severe episode, or if it was maybe one of their first episodes, it might be an idea for them to go and get checked over. But let your patient have some sort of say in that. That they might want to have some sort of input into that as well. But remember, you can never make anybody go to A&E anyway, but it's entirely up to them. But the situation there would be if you're sitting them down and they take GTN, their symptoms should subside. If they don't, what's happening? They're having a heart attack. Without any doubt, you've ruled that out, it's going to be the next thing. They're still sitting down. What might you look particularly to do with them as far as sitting goes? I know it sounds like a really stupid question, but there's a very specific way you want your patient to be sitting just now. What is it? I know it sounds like a really odd question, but there is a very definite position from a first aid point of view. If you think somebody's having a heart attack, that you should have them sitting in. And it's called the W position. So think of just a weird W, alright? So basically, you don't want a patient, like in this situation, sitting on a chair. Why?
Because their legs are down.
Their legs are down. What else? What might they do? They could. What else might they do?
They might fall.
They might fall. They lose consciousness. They're on the deck, and then you've got a head injury and all sorts of other things to cope with as well. You don't want to give anything worse than it is. If you've got a patient you suspect is having a heart attack, sit them on the ground, preferably in a corner. So I'm looking to a corner there. I'm thinking right behind the doors, maybe not so safe, but folk running in and out, but preferably in a corner. So the first part of the body and the head, so the torso and the head down to the bottom is the first leg of your W. That makes sense. Then what are you going to do? You're aiming to make a W shape. So that's the head to the bottom. What's that bit going to be?
Bring your knees up.
Yeah, bring the knees up. So the first thumb is your knees. And then the second thumb is down to the patient's feet. And that bit is pathetic. So nobody's got the size of feet that size. You don't have little tiny feet. So the best you're going to get is that. So yes, head down to the bottom is the first part of the W. Knees drawn up. Now, we're not talking of drawn up to a point where it's constricting their breathing. You know what that's like when you draw your knees right up to your chest. If you're really feeling cold, it can make you feel a bit cozier. You don't want to do that because you can't breathe properly. So just up enough that you are reducing all of the irrelevant blood flow. Remember we spoke about that last week. You don't want any irrelevant blood flow bothering going down the legs at all. You need it all to be here and here. But you keep your patient upright. Why would you keep your patient upright as opposed to lying down? Think about the signs, or particularly the symptoms that the patient's feeling. Why is it not a good idea to have them lying down? Which of these symptoms that you have stated already would make lying down not a good idea? Yeah, in addition to what else though? Why would you think it would be a good idea to lie down with chest pain?
Because they probably feel like they're being crushed.
Yeah, which would enhance what else that they're already experiencing. the panic and the lack of being able to breathe. Any of you who can't breathe, any of you who have ever had an asthmatic attack or any other constriction of your breathing, the last thing in your mind is to lie flat, isn't it? I mean, generally, if you're choking, you don't go, I'm just going to lie down for a bit. You stay standing. In fact, people who are sitting when they're choking, stand up. You need to have that feeling that you can have a good airflow in. So, yeah, keep them sitting up. The only time your patient who's having a heart attack should be lying down is if they've already lost consciousness. Then that way the chances are they'll stop breathing anyway, so it's not going to make anything feel any worse. So W position and keeping them sitting up. You've already tried the GTN, that would be your treatment for angina. It hasn't worked. Should your patient then lose consciousness, what's your next line going to be?
Dr. ABC.
Yeah, so you can wipe out the D bit because you've kind of checked the dangers, you've been there for a wee while already. Checking for response, again, if you've been with your patient for a while and they lose consciousness, they're not going to be responding anyway. It's not that they'll just have closed their eyes for a wee while, they're not just going to have a wee snooze. They're just losing consciousness completely. And then straight into the airway bit, alright? Remember that all the time. Don't go straight for breathing. If you don't check that the airway is patent, no matter what your breathing's doing, you're not going to make any difference to the patient. So have a think about that. Look at that airway, tip the chin back, make sure it's all nice and patent, make sure that they haven't vomited. If they have, you need to scoop out contents to the mouth. I know. But you do need to do that, and then start checking for breathing. Dead straightforward. If they're not breathing, straight into CPR. Always remember you need to be phoning 999. And remember what we spoke about last week. Quite often, actually, did we talk about this last week? Quite often, if you're on your own and 999 will phone you back, it's really hard to do what you need to do and still chat to somebody on the phone. And then I'm saying, you sit there with one ear holding onto this and try to do something else with the other two hands. But they mean well. They really do mean well. They're very, very helpful. A lot of the time they're saying, is it nice and impressed today because they're phoning you from Glasgow? But you know, it's fine, but it is quite a trick to do. So yeah, your CPR, you get your patient to hospital as quickly as possible. This is your prime time for if you've got a defibrillator in the room or in the building that you would be calling for that. Do you know where your defib is in this building? Mm-hmm. Okay, do you know where yours is stored away then, Denise?
Yeah.
That's good. What about Dumfries, do you know?
Yeah.
Right, come on then, so where is it then? I've never been to Stornoway, so I can't check, but I have been to Dumfries. Whereabouts is your defib in Dumfries?
We have two. We have one just down from the tutorial room next to the patient toilet, and then we have one in between two surgeries all over the clinic. I think it's outside surgery 50? 10.
That's quite impressive, because that's not a huge building to have two in. That's pretty good going. Nice work. So where's your one in Inverness? Right at the very front. Dental reception. Ah, right, no, that's fine, yeah, that's good. It's good to see that might be more where it's needed. I would imagine they might have one at the front reception too, the main reception as well. No, that's fine, it's always good to know. Okay, so, again, just be clear about what it is that you're looking for. Your signs and symptoms are going to be fairly similar between the two anyway. Angina, it should get better if they've taken their GTN spray and if they sit down and relax. Your situation should always be, in every first aid position that you find yourself in, is that you are calmness personified, you are relaxed and you will fix everything and make the world a better, shinier place for everybody once you've dealt with this, and that your patient feels that you are in control of the situation. And like I said last week, you can be panicking yourself into a right state, but don't let that show. Right, that can all be alright going on inside. Whenever if you ever do get into a situation of having to deal with a major first aid situation, and you do all of that, gliding like a swan, freaking out underneath, but gliding through it and dealing with everything calmly, don't be surprised if afterwards, when your adrenaline crashes and burns you, that you crash and burn. And quite often people get really tearful after situations like that, really terribly upset, because they've just been holding it together for such a long time. It's like a kind of emotional migraine. You know, it's like it's a headache, you're not feeling right, but that's a very natural thing to happen too. Okay, so are you okay with cardiac arrest? You should be alright with it anyway, because we've done CPR before, but the signs and symptoms can be very similar, and just be careful about ruling out angina. Always be mindful about the silent heart attack patients as well. Okay, so what about stroke? Just have a wee think for a minute about what it is that's actually happening when somebody has a stroke. There's another little flurry of adverts going on the television at the moment, which I don't know if you've noticed, about awareness of stroke awareness. So, Dumfries says, you're still on the screen, sorry, I'm seriously picking on you here. Can you give me a couple, just one or two, signs or symptoms of stroke?
The face will start to drip. They can't talk properly.
Okay, that's fine. What about anyone else?
Confused.
Pardon?
Confused.
Confusion, yeah.
Balance.
Loss of balance, yeah, absolutely fine. So, what's happened when somebody has a stroke is that there's been some disruption to the blood flow to the brain. And that's usually caused by either a clot, which may have travelled from somewhere else in the body, or it can also be caused by an aneurysm. So there's something disrupting that flow. Again, it's that ischemic attack within the brain. And it's important then to come in there, and when I say the word ischemia, have you ever come across transient ischemic attacks as a statement? Okay, transient ischemic attack, or TIA, is a real thing. Okay, I don't just make up words and throw them together for you. Some people will experience transient ischemic attacks, and this is like a sort of little flurry of mini strokes that can happen to somebody. That they will present with slightly milder symptoms of stroke. They may have a small, short period of confusion, a temporary drooping in the face, a bit of a weakness down one side, but it passes. And then it might happen again, and it passes. And then it might happen again, and it passes. It is quite often seen as a sort of precursor, as a kind of warning sign, things are not right, there may well be a bigger stroke coming. Just as easily though, somebody can have transient ischemic attack and never have a stroke, but it can be a warning, and that's fair. That's it's a fair thing to actually then take heed of. But the signs and symptoms are just the same, but they will be transient in nature. But the patient still has to be seen as an emergency. So so you get this disruption of flow to the brain. Quite often this might be the symptoms that are shown or felt, or signs that are shown and the symptoms that are felt by the patient will or possibly can be preceded by a very severe headache. And we're talking about a headache like you have known no other. It's absolutely crushing headache. The signs and symptoms thereafter are commonly advertised as being fast. So you're looking for F for face, A for arms, S for speech, and T for time. So the face is that you will likely find one side of the face is drooping, or the patient has difficulty in moving that one side of their face. The arms bit is if you really want. If you ask your patient to raise both arms, they will be able to raise one, but they won't be able to raise both equally. There might be some movement, or there might be none at all. Speech can often be completely absent, slurred, or very confused. And the time part is basically it's time to call for help. It's critical for anybody having a stroke that their help is received for them as soon as possible. I mean, to be honest, let's be honest, it's the same for everything. But the time it takes to get somebody looked after following a stroke is key depending on where they live. What you really want is to get that person having a stroke right outside a recognised centre for excellence. That would be great. Inverness, I have to say, Rigmore is not a stroke recognised centre for excellence. They tend to be in Centre Belt and Aberdeen, but it's the nearest centre for excellence that we can come up with. And it's still 2.5 hours away if you live in Thurston. But it is the best that we've got. So the time for getting that treatment in place is absolutely imperative. So face, arms, speech, and time to call for help. So you've done that, you've come across your patient, they're giving you all of these signs and symptoms, you're quite clear about what's going wrong, and remembering again, they will be absolutely terrified if they're still conscious. They're going to be having a fairly clear awareness of what's happening to them. You need to be, again, that first aid swan. How are you going to look after your patient then until the ambulance comes? Think about the whole part of it. Yes, you'll be reassuring. What position will they be in? What would you need to do for them? What do you need to be mindful of? Start off in Inverness. Can you think of anything?
Recovery position.
We'll come back to that.
Okay.
Does anybody want to suggest a different position?
The W position.
It's not a bad one. Okay. Anyone get anything else out there in Dumfries or in Stornoway? What kind of position would you think about for your patient who's having a stroke?
Was that sitting up position or like raising their legs?
Okay, you're all on pretty much the right idea. I would recommend sitting up rather than lying down. The recovery position is grand if they've lost consciousness. So that might come. So you need to always keep the recovery position in mind. It's usually better, again, because of that cripplingly sore head, if you can keep your patient upright. Remember what we said last week, if you've got a patient who's lying flat, they've got that immediate loss of feeling of dignity and of value and all the rest of that. So try and minimise the number of times that you would keep somebody absolutely flat on the deck, because there is a wee bit of a sort of power issue that could be seen there. But in this situation, definitely keep them sitting up. Again, not on a chair. Why? They will fall off. They can't actually balance anymore. So again, you don't want the person who's having a stroke to end up with a fractured shoulder as well. So sitting again in the corner of a room. I'm very fond of the corners of a room. I clearly sit a lot of time there, but sitting in the corner of a room, and that way they're propped up. Or in a chair. I mean, it can be in a chair that's got a supportive side. You know, I'm just not talking about these sitting chairs. Somewhere that they are supported on the side that is weak. It's an idea to keep the legs up in the W position, but if they've got a weakness in one leg, they won't be able to maintain that. So you need to think again about that balance. Again, you're needing to think about the patient's dignity and their well-being. What often happens, you should know this 100%, when you have just hammered somebody's face full of local anaesthetic. What do we also have that charming side effect of local anaesthetic in the mouth for? What else happens? When you've absolutely hammered somebody's gums with local anaesthetic and their lips are all swollen, what else happens?
Dribbling.
They dribble all the time. Nobody wants to have to do that, believe me. And then there's somebody having a stroke. The last thing they want to think is, oh, God's sake, I'm sitting here dribbling like an infant. You need to think about these things. It's so having something that they can use, a tissue in the hand that they can use, allow them to dab their mouths as often as they possibly can. Now, it very much depends on where in the brain this bleed or blockage has occurred. Will depend on the severity of the symptoms that you're being shown. The nearer it is to the midpoint in the brain, you might actually see symptoms on both sides. You're not going to be, it doesn't actually matter that much, you're treating the signs and symptoms anyway, it just gives you a slightly more understanding. The nearer any bleed or blockages to the speech centres of the brain, then the likelihood is that there will be no speech at all, there will be incoherent noises, but the actual speech might have gone. It could be severe enough that the patient is completely unconscious right from the word go. Now, at that point, if that's where you come in as a first aider, it is fairly irrelevant whether or not they've had a stroke. The key thing there is they're unconscious. You need to make sure that they've got an airway and that they're breathing and that they are kept safe. So in that case, absolutely, a recovery position is the key thing. And that way, if they stop breathing, flip them onto their backs and you can start doing CPR. But the time is critical. You absolutely have to get your patient to hospital as quickly as you possibly can and as fast as possible. Reassuring them, getting as much of a history from them as is possible. But remember, when people are confused and upset, they might not want to share much information with you. Does that make sense? Okay. What's the average age group of people that will have a stroke? Nice. What do you think? I mean, you're far more inclined to be having or seeing strokes reported in people in their much older age, you know, well over 50, but, you know, 65 plus, the incidence definitely raises. Is there a sort of limit on it? No, there absolutely isn't. Youngest patient I've ever looked after who had a stroke was 3. And that was a genuine stroke, an absolute stroke. One of the staff that I work with on a daily basis has got a child the same age as my son, who's 21. She had a stroke 10 years ago. She was 11. So there is absolutely no hard and fast rule to any age. There will definitely be predisposing factors to that. You know, people who smoke, people who drink, people who have, you know, high blood pressure, any other. Diabetics can be some increased issue there because of use of insulin and the friability of the vessels, but there will be certain indicating factors where risk is enhanced. But to say that no child will actually present with a stroke. Because I do remember, I mean, I was working in the south of England at the time, and this child was brought in, and we were told, getting a 3-year-old coming in, and it looks like he's had a stroke. And I remember the receiving paediatrician saying, well, that's not really likely, let's just wait and see. And oh my word, I mean, there was every single presentation was right there, that absolutely drooped face, absolutely unable to move the left side, very incoherent speech, dribbling, everything, and freaking out, absolutely freaking out. Not to mention his parents. I mean, they were just in bits. So there was a wee bit of a feed going on there anyway, but it's just mindful of, you know, the impact that can have, and that it can happen at any particular age too. Okay, so you're all right with strokes and all things hearty and otherwise. Okay, that's fine. I'm just trying to think about what might be a natural progressor here. I'm looking at my lovely list here. I mean, when I wrote them all out last week, I was thinking, right, that makes an order for there now. I can't see what my order meant from last week. Okay, but we'll keep on the theme of the possible losses of consciousness then. And if we go on to things about, and this will be very brief, looking at things that will cause people to faint. What actually happens in faint? And can anybody, for an extra, you know, praise, tell me what is the medical terminology for a faint? Well, that's quite a good one. There's also another word, vasovagal attack, yeah, that can be, but that can also be caused by somebody like nipping their neck and going to faint. What else about, what's the other, it's a great word, it sounds so much more dramatic.
Is it a syncope or syncope?
Absolutely, syncope.
Syncope.
It just sounds awesome, doesn't it? I think it sounds like either a flower or some sort of awful disease, but syncope. I've had a syncope, you know, I'm feeling a touch. No, I don't think actually feeling syncopatic is an actual thing, but never mind. But it's a good word. Yes, that's all it is. So what often are the causes for fainting? What are the most common causes for fainting? Stress, absolutely. Anything else?
Dehydration.
Dehydration's a good one.
Low blood pressure.
Low blood pressure, yeah.
Fear one as well.
Sorry, what was that one?
Fear.
Fear, yeah, absolutely. It's a kind of shut down, yeah.
Hypoglycemia.
Could be hypoglycemia, but we'll come back to that different kind of fainting later. Okay. Anything else?
Like illness.
Not doing terribly well, yeah. The most common one that I'm called to as a first aider is people not eating breakfast, just saying. Just not, I mean, I'm not making a comment on that because I'm probably going to guess it might be 3 people within this VC situation who might not have had breakfast. I'm just guessing at 3. So, yeah, not having a breakfast is the most common reason that I'm ever called to the first aider to deal with somebody fainting. So you go and say, all right, yeah, have you had breakfast? No, fine, here we go. Off we go to the canteen. But these are very common things. Standing still for a long time. You know, if you look at the changing the guards, these poor blinking soldiers in their massive bearskins, and falling over all the time. So standing still can. There's a whole host of things can. Quite often, I mean, it's really just a sort of saving mechanism for the brain. It's like suddenly everything's a little bit too much. And we'll just have a wee bit of a blackout here, and then everything can get back to normal, hopefully. You notice, and it's not fainting, but in very young babies, and I mean very young babies, if you take them into a room where there are masses of bright lights on, and there's loads and loads and loads and loads of noise, and there's lots of chat and all sorts of action going on, loads of movement, loads of colours, lots of everything else, what a baby does is go to sleep. Because the brain can't cope with that. It's just like, well, too much information here. Whereas we as adults would get up and move out of that situation where we find it overwhelming, or we might faint, but a baby would just sleep, block it all out, and hopefully it'll have gone away by the next time I open my eyes. And it's a very good coping mechanism that the brain has got in place just to give you a wee bit of chill out space. So, what do you need to do for somebody who's fainted? I mean, what actually happens? How long are people out for? It is seconds. You know, people will say, oh, I fainted and I was out for 10 minutes. That's not a faint. That is absolutely not a faint. That's something different. That's a loss of consciousness for a completely different reason. A faint is seconds. Generally, from the time a person begins to feel, and if ever you have fainted, you might have similar sort of symptoms that you would feel, you kind of get a weird sensation within the vision. It becomes a wee bit blurred, everything gets a bit loud and a bit shiny, things just feel a bit strange, and you know something's going to happen. Tends to be from the minute that that starts and you lose consciousness, by the time you hit the ground, you're actually coming round again. And it's not hitting the ground that makes you come round, that's how quick it is. It's seconds. Hit the ground, woof, back up again, and you're actually okay. If somebody's with you as a first aider, what should they do to look after you until you feel a bit better?
Raise your legs.
Raise your legs. It's the easiest thing. Just grab legs, hold them up in the air, put them up in a coat, put them up in a chair, just something like that. Then what?
When you come round, get your sugar.
Yes, find out what it is that's happened. So, is it something that's giving you a fright? Do you need to actually just take a little bit of time out and sit down and relax? Drink something warm and possibly sweet, or cold and sweet, do if you haven't got anything else anyway, but just something that's actually going to make you feel a little bit better. Take great recommendation from Harry Potter. See a Dementor? Eat chocolate. It's just the same sort of thing. Always makes everybody feel better. So use things like that. Something like that will generally make somebody better. If it's something repeated, there may be something underlying that maybe needs to be examined a little bit more. And quite often one of the drawbacks of it being an on-call first aid is if you're called to see somebody who faints, you fill out all the details, you put them back to class, blah, blah, blah. You don't see that there's actually a pattern forming there. The health and safety officer will see all of that data. Then that will alert us to say, right, actually, hang on, this isn't right, this is happening at the same time. Every day, there's something not right. And it tends to be, as I say, from the college point of view, not eating breakfast. And quite often it will be because a student hasn't got access to breakfast and they haven't got any money to eat breakfast, so we will just come up with the goods of the bacon roll. Always keep that in mind if you want to think of it all. But yeah, 9 times out of 10 that is what it might be, but it could be an underlying infection, it could be a low blood pressure, that might be a transient thing, but it is over quickly, it's not a massive deal. At the same time, though, also in that list, I've put panic attack in at the same point, because quite often you'll find if somebody's having a panic attack, one thing that they will do is faint. In fact, the last student I dealt with who was having a panic attack managed to faint 4 times within about 5 minutes, because I could not get her to start breathing in a safe way. Just couldn't do it. And the more you have somebody who's breathing from the upper part of their lungs, and who basically is just going, then the more quickly they're going to faint. They're not allowing a really good clear out of any carbon dioxide. They're building up, building up, building up, building up, and faint. So then they come around, build up, build up, build up, and faint. And so it goes on. So it's important to get that breathing properly sorted out. So, and a person having a panic attack, and I'm quite sure you will have patients coming in, you've maybe come across who are experiencing the same thing. Again, it comes back to it, your calmness is invaluable, absolutely invaluable. You are in control of that situation. And if needs be, sit facing your patient and make them breathe at the same rate as you. You can't make them breathe. I'm not taking that list, but encourage them to breathe at the same rate as you. And that's not you going either. They've got to breathe deep and slow, preferably into the nose, out through the mouth, into the nose, out through the mouth. Or get them to try the nostril breathing. There's a specific way for that, where you breathe in through one nostril, hold the breath, cover the other one, and breathe out through that first nostril again, and then breathe in, cover over, breathe out. And really the benefit of that is, that's a good attempt being made on that, so breathe in one side, and then hold it, cover the other one, breathe back out again. The benefit of that is not just the fact that you are making somebody breathe in a very rhythmic and steady manner, you're giving them an activity to do, to focus on. They're not just focusing on themselves and thinking, right, oh God, right, okay, now I'll do that nostril, then hold it, then that nostril. And then that in itself, the minute you take the focus away from, I'm seriously panicking here, then it actually allows the breathing to slow down anyway. Okay, so being calm, very collected. Again, be aware that there might be some underlying thing that you need to be considering as well, that the patient might well be aware of that too. Okay, I'm going to let you go for a wee break in a wee minute, but if we just cover over 2 more things, right? We're going to have a look at asthma and choking. So big hands up first of all. Are any of you in the 3 rooms asthmatic? No? Just one. Thank you for sharing that. Okay, now can I ask, and feel free just to say, no, I'm not replying to that question. Do you take fairly regular medication for it?
Yeah, I'm on the asthma spray, on brown inhaler and blue, but I'm using brown every single day, and the blue one, which is sublingual, that's whenever I can't breathe properly during the night, mostly. And it's happening about maybe every 3 days.
Okay, right, that's fair enough. Okay, so that's a key thing to do there. We'll come back to the very specific colours of your inhalers, because that's a very important thing as well. Okay, so what is happening in an asthmatic attack then, somebody in Inverness? What's happening?
You can't breathe out.
Yeah, so why not? What's happened to the airways that suddenly becomes difficult?
Aren't they constricted?
Mm-hmm. What might be the cause of that?
Allergies?
Yeah, it's a feasible option. Yeah, okay. What about in Dumfries? What is happening? And you're not allowed to answer. If you've already got inhalers, you're not allowed to answer. But what are the likely causes of somebody having an asthmatic attack? What is it that's happening within that? What's causing that constriction to happen?
That the lungs go into a spasm.
Well, the airway tends to be the sort of bronchus that goes into a spasm. It can be caused by an allergy. Anything that is perceived as an irritant by the lining of the airway will cause something like an asthmatic attack. Now, people can have asthmatic symptoms without being asthmatic. So, that's quite a clear thing to be aware of, is that sometimes people recovering from something like pneumonia or a serious chest infection, pretty much the same thing, might experience symptoms of asthma, but they will tend to be transient and they may just be very short-lived. People who experience asthma on a fairly regular occurrence, there is something which is causing the irritant to the lining of the airway. And that can be an allergy, which could be a foodstuff, it could be ingested, it could be inhaled, it could be stress-induced, it can be exercise-induced, there could be cold weather in particular, or change in temperature, change in the humidity and the atmosphere can trigger a narrowing of the airways as well. So there can be quite a significant number of causes there. If you fall into the category of being blonde-haired and blue-eyed, you tend to have more likelihood of being asthmatic. You also tend to have more likelihood of having eczema. But that's just useless information. You're going to remember that now.
Green.
We're fine. Mine are blue. Yeah, happened to me. So there are sort of tendencies. When you look at research, those are the sort of tendencies. But so the key thing about asthma is that you know how to deal with it. It's a very, very common disease. It's also a very commonly underdiagnosed disease. And yet at the same time, quite often you'll hear patients saying, well, I went to the doctor because I've got a cough, and give me an inhaler, I'm not asthmatic. Yeah, but you might be just at this wee bit of time, you might be needing something to support that. But it is often underdiagnosed, and with significant consequences. It can be quite a challenge to get the absolutely right treatment for a patient with asthma, because so much of that depends on their full understanding of the support that they have in place to cope with their asthma. Most surgeries or GP's practices now will have an asthma nurse or an asthma clinic that's run by either the nurse or the GP in the practice, because that helps to support the patients. So, signs and symptoms of asthma then, of an asthmatic attack then, in Inverness. Let's keep that here just now. What signs and symptoms might you be looking for and see your patient experiencing?
They start wheezing.
There could be an audible wheeze, yeah. Sometimes there isn't, but there could be, okay? Anything else?
Could be breathless.
Yeah, shortness of breath. How might your patient look? Now that sounds weird. Now, they're not just, pardon?
They would panic.
They can be a bit panicked. But think about physically, if you can't breathe, what do you do with your body in order to try and enhance the breath you're trying to take?
Coughing.
You could be coughing. Quite often you'll also find that patients experiencing an asthmatic attack will sit with their shoulders up. Now, actually what they're doing is trying to increase the volume capacity of their lungs. They're trying subconsciously almost to make that lung space a bit bigger to try and get more air in, but actually you think about doing that, you're really putting a wee bit of a constriction in your airway, so it's not really helpful, but it is quite common to see that, very tight, anxious shoulders. If you can't breathe, for any of you who have experienced something like that, it does make you feel panicky, it does make you tense, which in turn makes it more difficult to breathe. So it is a very, very vicious circle. So they could be coughing. If your patient has got to the point where they can't cough any longer, that's not a good sign, because they haven't got the inhale capacity to be able to cough. You have to be able to go in order to cough. And if your patient's got to the point where they can't do that, that's not a good sign. It's also not a good sign if they can't talk easily, because again, you need to inhale in order to make voice come over your vocal cords in order to speak. If they can't do that, then they might not be able to speak. That's not a safe situation to be in either. Okay, so they might have an audible wheeze, they might be looking a bit tense. What then, in Dumfries, what is the first thing that you might want this patient to do?
We just try to reassure them first, I guess, to calm them down.
You want to keep them calm and to be absolutely, again, you are the swan that's dealing with this. What else do you want them to do though? What do you hope that they'll have on them?
Inhalers.
Yeah, so which colour inhaler?
The salbutamol one?
Yeah, the blue inhaler generally tends to be blue, so that people can universally recognise what it is. You want them to be able to take the inhaler that contains salbutamol, which is often written on the side as Ventolin. The salbutamol acts as a very short-term vasodilator. Okay, so it will act in the airways and it will help to reduce some of that inflammation in the airways. And it acts very, very quickly, usually. Really very quickly. Now the critical bit about a Ventolin and the critical bit about having a patient who's having an asthmatic attack is their technique in being able to take the inhaler. Because if you don't use an inhaler properly, it's virtually worthless. So you need to be able to get your patient relaxed enough. They need to be able to exhale out as much as possible. Then, if depending on what kind of inhaler they've got, if you think about the technique that you need to do several things at once, it's quite a tricky thing to multitask. Generally, you would want to exhale, put the inhaler in the mouth, and at the same time as taking a very sharp inhale, press the inhaler once. Okay, so you've got to go and press at the same time. So in that big breath, the drug is actually making its way down into the airways. If you look at somebody who's really, really wheezy, that's possibly not going to happen. Some patients will have what's called a spacer device, which I don't know if you've seen. It's like a massive big water bottle. It looks just like that big water bottle. It tends to be slightly rugby shaped, and the inhaler fits in at one end and the mouthpiece goes into the patient. You can press the dosage and then the patient breathes normally. It's actually quite a nice, efficient way of not having to do that, oh God, which did I press first, and falling over because you've forgotten. It's quite a smooth way of doing it. Why is it also quite a safe thing? This is a random comment. Why is it quite a safe way of taking an inhaler using a spacer device?
It's more accurate to take the spray in, because some people they basically they spray, but it's not aggressive as much as it should be, because they're not doing the right technique.
Yes, quite often that's one of the major benefits of it. But in addition to that, by using a spacer device for taking any asthmatic treatment, you're also reducing the impact or the possibility of a breakout of thrush in the patient's mouth. And as dental therapists, you need to know that, right? Okay, so there you go. But that can reduce that, and it's quite a sensible use to have. But most people are not going to be walking about with this massive big thing. You know, people carry tiny handbags, but, well, women carry tiny handbags sometimes. So, yeah, it's important that the technique is right. So if your patient's having an asthmatic attack, you want them to take 2 puffs of their Ventolin inhaler. And if that doesn't work after a few minutes, you can actually encourage them to take 2 more. Now, potential side effect of that? Is there a side effect? Well, it's a side effect to any drug. What's the potential side effect of taking too much salbutamol? It tends to be that because it's a vasodilator, you might then see an increased heart rate. You might see a patient that's got a slight tremor. If they've taken too much, they might be a wee bit shaky. It can also be, however, though, I mean, just last week actually, I dealt with a student who was having an asthmatic attack, and she had a terrible tremor, and part of it was because she had taken too much Ventolin. But in addition to that, she was definitely panicking as well. So the 2 things were not making this a positive experience for her at all. So yes, it's the blue inhalers that you want to take. With regards to the brown inhaler, should you have any confusion about which to give, don't ever bother giving the brown one. If a patient can't inhale the brown inhaler properly, it's not going to do them any good anyway at that particular time. The brown inhaler will contain steroids, which is anti-inflammatory, and they need to be taken regularly and over a long period of time in order to affect the natural swelling that any patient might have who's got an asthmatic tendency. They need to be taken fairly regularly over a fairly long period of time, and will not have a direct impact on somebody having an asthmatic attack. Always got to be blue, so always go for the blue one. If after a little while your patient has had 4 puffs of their salbutamol, say, and there's no change, what should you do? Absolutely, call an ambulance. You're not going to fix this at that point. If they've taken the maximum dose that you, as a first aider, feel safe that they have taken, they need to be seen by somebody medical. Now, the first thing that they're going to get given is more salbutamol, but at least then in a medical situation they can manage that potential tachycardia, they can manage anything else that might happen as a result of that, and they will be safe. And they will probably give them nebulized Ventolin, which will be nebulized as a mist form through water, which is much, much safer. You put a mask over, nebulize it, the patient just breathes away and in it goes, and it generally works quite well. So your only other possible situation that might arise is that your patient loses consciousness as a result of not being able to breathe properly. You're back to your ABC again there. Check that airway. Patient's not breathing, start doing CPR. They are breathing into the recovery position, and monitor them very, very closely, but get help for them as well, okay? Choking, if we touch on that fairly quickly, and we'll do an anaphylaxis after the break because they're all much of the same thing. You've probably all seen Mrs. Doubtfire, best choking episode ever, so always use that as a measure of what you should do if somebody's choking. You don't have to dress up as the opposite gender, but it's entirely up to you. So choking, all that happens there is very straightforward. You'll all have done it. You'll all have choked at some point. Something gets lodged at the point at the back of the throat where there's a decision to be made for any foreign object. Do I go down that airway, or do I go where I'm meant to go and into the esophagus? But I can't quite decide, so it just sits either way, or maybe just actually tilts one way more than the other. Patient can't breathe. Absolute panic ensues. You all know what that feels like. It is never something that you're going to forget. Even if you know you're going to be okay and you can cough and you can breathe and everything, it's still a frightening thing to happen. So again, a patient who's choking will tend to stand up. Again, that enhances their lung capacity for them, or so they feel. They will often tend to grab their throat. That's instinctive. It's like, just get this whatever it is out of here. So they'll often grab their throat. They'll want to stand up. They need to feel that they're going to be safe and A-OK. So again, you are the first aider or physician here. You need to try and encourage your patient to cough. Now, if they have something that's sitting more over their airway, again, remember you need to be able to breathe in to be able to cough. If you can't do that and they can't cough, so be it, but you need to encourage them to do so. Alright? Your action then is, regardless of how big they are, you need to think about what your position is going to be here. You want to get your patient who's standing up. If the top of my finger is their head and my elbow is their feet, you want them to bend very slightly from the waist. Very, very slightly from the waist. You need to just slightly improve that gravitational pull. So a slight bending from the waist. Make sure that you're calm and everything else. You need to stand to one side of them and take the flat palm of your hand and slap them hard. I mean really, really hard. Right in between the two shoulder blades. So that high up on the back, flat of your palm in line with the spine. So not cross the way, just hard smack that way, okay? Does that make sense? Very, very firm slap. Now I'm trying to remember what the routine of it is. I know it's 3 cycles. Pretty sure it's 5 times. So you slap them hard 5 times between the shoulder blades, as firmly as you possibly can. That's pretty fine. But upright hand and upright in line with the spine, but very firm. I don't expect you to practice on each other with that firmness, but a really hard smack. You're trying to force whatever it is in there straight out, and that might be enough, in which case that's amazing. So if your patient spits out whatever it is that is in their mouth, great, you can stop. You don't have to do any more. You don't have to be I'm in the zone now, and they keep on going. No, if it's come out, you can stop. They're all right, and they can breathe. They're quite happy. But if that doesn't work, you need to then do, well, I don't think Mr. Heimlich, who was recently passed away, and I liked it being called Heimlich anymore. You want to do what's called chest thrusts. So basically what you have to do, stand right behind your patient, make one hand or into a fist, and you place that fist at the soft part of your solar plexus. So if you feel right at the base of your sternum, so that very soft area right beneath your sternum, the bit that you know if somebody punched you is going to wind you. That's where you want to be. You want to wind this person. Your hand there, your other hand comes round on top of them, on top of your hand, and you pull back and up at the same time, fast and hard. So back and up. So again, you're trying to mimic a force on the esophagus that might push air out and throw that object up. Now, you can repeat that cycle up to 3 times. Now, the chances are that your patient is not going to stay conscious for that length of time. If something is obstructing their airway, they're likely to faint, and that's fine. They don't need so much of a faint, they're likely to lose consciousness. That's absolutely fine if they do. What might happen when they lose consciousness? What do you really want to happen when they lose consciousness?
The muscle relaxes.
Absolutely. Muscle relaxes, foreign object can move. That's what you really want to happen. You don't have to try and make this guy lose consciousness or this person lose, but you really, really want that to happen. The minute somebody's unconscious, their muscles are relaxed. Your patient who's choking, every muscle in their body is focusing on breathing and is as tense as anything. You need them to be relaxed. So if they lose consciousness, hope that that object will then move. As soon as they lose consciousness, you need to go straight into ABC. You need to open the airway and check. Now you know there's something in there, and it might be that you can't see it, and if it's right at the back of the throat and you can see it, you can't go in and take it out. For one reason, if your patient goes into some sort of spasm and maybe has a convulsion as a result of lack of oxygen, your finger's going to get bitten off, so don't do that. And also you run the risk of, if you don't know, it's like Titanic, it's like an iceberg, you don't know what the rest of the size of this object is. If you're trying to grab it, it might be huge, you could well push it further down. Okay? So don't try and remove it unless it's right at the front of the mouth. You know there's an object there, you still have to check the airway and you still have to check their breathing. If your patient is breathing, hallelujah, that's your best case scenario, other than them spitting out earlier. That's a good case. You've got a good position there. You put your patient into the recovery position and you call for an ambulance. Check their breathing continually, flip them over, be prepared to do resuscitation if not. If, however, your patient's not breathing, again you've got that situation where you know there's something in there. You still have to breathe for them. So you do full CPR, so you go straight in to your 15 compressions, your 2 breaths, and in the hope that doing compressions, you're actually going to force this thing out as well. So you're keeping an eye on that airway. You don't pause in your circulation. You're keeping an eye every time you go to do breaths. Is that foreign object there? No. 2 breaths, whether you know that they're effective or not. So you know from when you did your CPR, doing an effective breath, when you're doing CPR, is when you've done a breath and you know in the corner of your vision that the chest wall of the patient is rising and falling. That might not happen if you're doing CPR on somebody who's choking because of that obstruction. Nonetheless, you still need to try. There might be some little trickle of air getting through. There might be something like that. And I'm quite sure when Pamela was here years ago doing the second year of it, I did tell a story of when I first started nursing actually. I had a patient come in with pneumonia, and it was discovered, she was only 14, did a chest x-ray and found that she had this massive infection in her right lower lobe, I think it was, and they couldn't work out what it was, and people actually they were quite concerned. They thought it might be some fairly unpleasant, possibly malignant looking mass, but actually they managed to fix her pneumonia, but then discovered that the centre of this mass was a foreign object. And they had to go in and do a very, very sensitive little bit of keyhole surgery to extract this little foreign object, which was, none of you have got one, the top of a Bic pen. The actual lid of a Bic pen. The one that's got the piece down the side, that you can click it onto the side, but it's got a hole at the top. Something like them. Are they slightly holed at the top? Yeah, very similar to them. The Bic ones have got a clear hole rather than a crosshair. That was what she had inhaled, and she recalled once they found it and said, "What?" And she said, "Oh, I still remember." She was at school one day, she was working on the board, pen in her mouth, chewing, had the actual lid in her mouth at some point, remembers coughing and choking and getting a bit carried away and her friends all smacking her back and taking a drink of water. She'd inhaled the whole pen lid, the whole thing, without being aware of it, right into the bottom of her lung. Where a little infection set up because her body went, weird foreign object, get this out, and loculated a neat looking little abscess around it, but that was what she'd inhaled. So it's quite bizarre in things that people can cope with and can survive with. But yeah, your choking is key, your timing is key, and your calmness as always is critical. Okay? So you are chuntering through them, but you're needing a break. So do you want to go off and have a break now? And if you're back about just before 1:45, so that'll be about 15 minutes. And again, we'll be looking at finishing up between 22:30. All right? Between 11:30 and 22 we'll be looking at finishing. So we'll see you very shortly. Right, everybody, we're all back in the land of the living. We're all hydrated and fed, so nobody's going to faint now because we've had something to eat or drink. That's absolutely fine. Okay, so the next thing I want to have a quick look at then is, on my list of things that are grouped weirdly together, was alcohol, drugs and anaphylaxis. So we'll take anaphylaxis first, as we're talking about difficulties with breathing. So, can anybody tell me, Hanif in Stornoway, can you tell me what is anaphylaxis?
Is it when someone's having like difficulty of breathing?
Mm-hmm. Do you know what causes it?
Is it like some kind of like allergy? Yeah.
Generally, an anaphylaxis is, the term just simply means that it's an abnormal reaction to, an abnormally extreme reaction to an irritant or something that the body doesn't recognise as being compatible. with any of the tissues in the body specifically. What are the most common causes of anaphylaxis? Dumfries, do you know? Sorry, what was that? Yeah, okay.
And also antibiotics.
Antibiotics, yeah. Anything else? Peanuts. Wasp stings. Actually, the list is fairly endless. Anybody who has a tendency towards anaphylactic reactions, it will be whatever the personal allergy that they have themselves. So pretty much anything can cause an anaphylaxis, and you don't necessarily have to have a recognised allergy in order to experience anaphylaxis. People can just develop anaphylactic shock as a result of one contact with often a substance that they've had contact with before. It can be just a completely random occurrence with no previous history at all, but that does tend to be quite rare. So anaphylaxis is, as we've said, an extreme reaction to something, and it is referred to as anaphylactic shock because, again, it's about that cessation of circulating fluid within the body. Not that necessarily anything is bleeding, or we think that there is a loss of fluid from the circulation as a result of extreme swelling and inflammation. So, what are the signs and symptoms that you might notice of somebody with anaphylaxis? Anybody?
They can't breathe.
Yeah. Anything else?
Swollen face.
Absolutely. Red, blotchy, swollen face and neck. They're the most common signs that you will see, and the symptoms that the person might be feeling is that they have a real difficulty in breathing, they suddenly feel very hot, very distressed, and really very, very unwell. What's your treatment going to be?
Adrenaline.
Yeah, so you would hope that anybody that you know who has a tendency to anaphylaxis, as I say, there will be some circumstances where you don't know that, but if they have a tendency to anaphylaxis, that they will be in the possession of an EpiPen, so a pen driver that will administer a dose of adrenaline. There's nothing that, have any of you ever had to give an EpiPen or adrenaline? No. It's very, very straightforward. There's nothing that you actually have to do, and if you get to your patient early enough, they might have been able to administer it themselves. But it is a fairly significant dose of adrenaline that is administered into the body in order to counterbalance the extreme reaction that has been experienced by whatever the poisonous or the substance that's causing the reaction is. However, it is only one dose, so no matter if your patient does take that dose of adrenaline and starts to improve, they still have to go to hospital. This is still a medical emergency. There is still a likelihood that their airway may obstruct, and the likelihood therefore that they're going to collapse and that you have to do CPR on them. So immediately you suspect somebody's having anaphylaxis, then you need to dial 999.
Where do you administer it?
Like, leg's quite a good place for administrating a whole load of things, because there's lots of muscle, lots of tissue there, there's lots of hefty blood flow. It's not a bad place to go. And it, as I say, it's really very straightforward. There's nothing even that's to be sort of jammed in. It's usually a case of placing it against the skin, clicking a button, and that injects the needle into it. So nobody has to do anything complex with needles. So they should be held by every patient who has a diagnosis of experience of anaphylaxis. They should be carried by them. The number of times I would come across students who say, well, actually, no, I have anaphylaxis, but I don't have an EpiPen with me. Well, do you have anaphylaxis? Anyway, that's by the by. There's allergies and there's anaphylactic reactions. They're very, very different. I think if you put them in the scheme of things, you should get intolerance, allergies, and anaphylaxis. They would go in that order. Okay, so there are very minimal things to have input there about anaphylaxis. But the reason I grouped it with alcohol and drugs is because effectively what you're looking at there is poisoning. Although it's a substance that is in everyday things, or it might be an everyday occurrence for everybody else to come into contact with it, it has caused a sort of poisoning effect with that particular patient. So, alcohol and drugs I really just grouped together because really what we're looking at there is about how to cope, how to deal with poisoning situations, or situations where somebody has taken an excessive amount of something that is not going to do them much good. Okay? Alcohol is a fairly straightforward one. I mean, this is probably the one, like I said last week, this is probably the first aid situation that many of you will have already found yourselves in, where you actually are dealing with somebody who has been poisoned or has experienced high levels of alcohol in their blood. It's a difficult thing to actually justify what is the level of poisoning, how much do you have to take to be poisoned. It's the same as anything to do with alcohol and actually tobacco as well, as how much is too much, how much is too little, how much is exactly right. It's very much a fairly fluid situation. If I was to drink alcohol, I'd just fall off my chair. I mean, seriously, I've got such a low intolerance. Was not always the case, but I have a very, very low intolerance of alcohol now. So I just don't bother drinking it. Can't be bothered with it. I know of other people who can drink 4 or 5 glasses of wine and still be upstanding. And that's really significant. There was a report out yesterday about use of alcohol. What was it about? That's going to have to come back to me. About what was perceived to be heavy regular drinking. Heavy regular drinking, or heavy drinking, was deemed for a man to be whatever the units are that would equate to 4 pints of beer. Now, I know of many, many people for whom that is a daily occurrence, and that is a term of heavy drinking. So it is very much about a balance that we need to get as a society as well. We have a very weird relationship with alcohol, but that's for another whole other study date, which I won't give you, honestly. So dealing with alcohol poisoning, we're going to be looking at this in conjunction with everything else as well. Most of the situations that you would come across in a first aid where you are making sure that the area is safe and you're looking for signs and symptoms at the same time, bearing in mind that if you come across somebody who has taken too much of something, there may well be evidence of that around them. And you would be looking for the most clearly obvious things are, I don't know, a bottle of vodka rolling around the side of the floor, evidence of syringes, needles or other paraphernalia for injecting drugs. There might be bottles or tablets or pill pop packets or anything like that. There could be something that might give you an indication. It might be the situation that you're in that makes you think, actually, this is more likely to be here than it might be somewhere else. But it is all about that, taking that same information. You're looking, you're observing the situation, you're smelling things, you're trying to hear what you might be able to be aware of. It doesn't really matter. Your main aim is still your patient. Your main aim is still to prevent the condition from worsening and to preserve life. So they're the things that you have to do, and you have to use the signs and symptoms around you. So I can't really ask you to give me an idea of what sort of signs and symptoms might you look for if somebody's been poisoning, because there are far too many possibilities. If you're talking about food poisoning, that's a different whole case altogether. If you're talking about a drug overdose or somebody who has deliberately taken too much of something because they think it's going to be even better than just taking one, the variations on what those signs and symptoms are huge. And if in doubt, always go to Ask Frank. Always go to the government website, Ask Frank, and you will get all the information that you need to know about any type of drug misuse or any overdose situation like that at all. However, so your main aims are still going to be about maintaining life, make sure there's a competent airway. You also need to be able to give information to any emergency services that you're passing a patient on to, no matter how tenuous you might think it is. So if you come into a room and you see somebody who may have had an epileptic seizure, but there's half a dozen bottles of some tablets lying around there, that is still something you need to pass over as information. Because the two may not be connected, but they might be absolutely connected. It's not your role to make that decision, it's just information to pass on. So you may come across a patient who you suspect might have taken something. They may be displaying very confused behaviour, very excessively high behaviour, very excessively low behaviour. They may be incoherent in their speech, they may be terribly clear in their speech, they may be having marvellous ideas about how to fix the world, or terribly dull ideas about what not to do with life. It really just varies. Your key thing is to ascertain as much information as you possibly can. The key things that you need to work out are, what has that person taken? whether it be food, drink, drugs, whatever. What have they taken? How much did they take? And how long ago did they take it? They're your key things. So, what did they take? How much did they take? And how long ago did they take? Now, you need to make a wee note of those. If you can remember them mentally, then that's absolutely fine, because those are very critical bits of information that you need to hand over to any medical service. There are certain things that can be treated very quickly if they're in a poisoning situation, but the time is completely critical. There are certain drugs, for example, paracetamol, over a certain amount of time, you cannot treat the effects of an overdose. And it's a very short amount of time, it's only something like 7 or 8 hours. It's a really short amount of time. So you have to be very, very clear about what timing is there and what amount has been taken as well. If possible, keep a hold of any other evidence that you might have, like, tablet bottles, anything like that. Keep a hold of them, just put them in a pocket or in a bag or something like that, and that will be handed over to go to the hospital as well. Looking after your patient is always the main ABC, making sure their airway is clear and that they are breathing and that they have some sort of circulation that you might have to step in to maintain. The level of consciousness is likely to be flexible, likely to be a movable feast, but again, it's that airway, breathing and making sure that they're in a safe situation. They lose consciousness, recovery position, ABC if you have to, that's all as standard. If you have a patient that you know has deliberately ingested something, you have a few things that you need to do to try and keep this patient as safe. Remember, you're not allowed to worsen a condition here, or you shouldn't be putting your patient in a condition of being worsened by your actions. So if you suspect that somebody has taken something of whatever it might be, keep them as still as possible. Why would you do that? Why would you want to keep them still?
So they don't hurt themselves or you?
Mm-hmm. Yeah, there is another reason.
So they don't go and get more?
Oh, that's a good idea. Now, you see, inadvertently, you've kind of answered the question there, because the real reason that you don't want them to move around is that you do not want to speed up the ingestion of whatever is inside them. So when you move around, if you eat a massive meal and you do nothing for an hour, that meal is still there after an hour. It's still there after 2 if you don't move. If you eat a meal and then after about half an hour you get up and you go for a big walk, you're burning that off big time. If you've taken something that's inappropriate and you start moving around, you're going to have a rapid increase of whatever that substance is getting into the bloodstream. The calmer you keep your patient, the more inert you keep your patient, the slower that effect will be. Remember, you need to try and keep your patient in a situation that you can cope with them. You don't know what the side effects are going to be of whatever it is that they've taken, necessarily. For example, if somebody's taken too many Valium, for example, the first place that acts on is what? Breathing centre. So if you've got a patient who's taken a lot of Valium, you speed about how much they're moving, that gets into their bloodstream, their breathing system is suppressed and they will stop breathing far faster than if you just keep them still. So it's keeping that in mind. Keep them still. Do you encourage your patient to vomit or not? It's a tricky one. You're going to say one answer that's going to be wrong, you say the other that's going to be wrong anyway. So you're kind of in a catch-22. There are situations where you absolutely do not ever, ever make your patient sick. However, you do need to know that if they've taken something that can be brought back up again, that's the first thing the hospital is going to do. There are very, very definite situations where you do not want to do that because it will enhance the worsening of the condition. And that's where if you've got a patient who inadvertently or deliberately has taken something corrosive, and that would be something that maybe contains petroleum, like fluids, or as in like oil-based fluids which have a corrosive element to them, bleach, cleaning fluids that are corrosive, crystals that are corrosive, anything like that, you most emphatically do not want somebody to vomit if they've taken them. Because all that's going to happen is what burnt on the way down is going to burn just as much on the way back up. And there you will have a very serious situation in your hand because you'll have somebody who potentially doesn't have a windpipe for you to be able to do CPR with. And that's really critical. You need to be clear about that. Taking something that you suspect might be corrosive, you do not allow them to vomit. You don't want them to vomit anyway. Just keep them still, keep them calm. If they throw up, you need to keep the vomit too, alright? That has to go to the hospital as well. Being there as a nurse, going through vomit with my rubber gloves, looking for tablets, I have to say, I have been there and done that. But you do need to keep the vomit. Okay? Get your casualty off to hospital as quickly as possible. Hand over all the information that you can. Give over any evidence that you've got, which may or may not be connected. But always, always airway, breathing, circulation. If your patient loses consciousness, if they're still breathing, recovery position, keep them safe, keep them warm, keep them okay. It's not a fun thing to look after. I mean, again, also, you know, I was a paediatric nurse, and we tended not to get that many, significant number, but not that many, deliberate ingestions of anything specific. But we did get an awful lot of toddlers who just had not been in a household where safety was paramount, shall we say. And it was awful. I mean, quite often, you know, parents would come in with these little toddlers and say, "Oh, you're never going to believe that she's got a hold of X and Y and Z," and it was actually kind of a bit of a laugh. Oh, so not funny, so not funny, when you then have to give this tiny wee tot a massive whop of ipecac. Have you ever had ipecac? Oh, it's a lovely thing. It's a naturally occurring substance that causes no end of vomiting to happen. And you give them that in a little drink of juice, and then you sugar. And you sugar, and you sugar, and you sugar, and the sweet child sitting about absolutely happy, and then suddenly their wee faces change, and boy, they start vomiting, and they don't stop for ages. And you've got to do every bit of that to find whatever might be in there. It's not fun. It's just not fun. And all for the sake of putting something out of reach. It's not easy. But it's not a fun thing to have. But that will happen to adults as well. They will give them something similar to, if it's felt safe that they need to actually be given an emetic. So, basic principles apply. You just do not want them to move about. You do not want them to vomit. You do not want them to be dancing around too much. You want them kept calm. Gather all the evidence that you possibly can and get them off to hospital as much as possible. Things like bites and other causes of poisoning are key because they will present in very different manners usually. Dog bites are going to be more common, or any animal bite are going to be more common than likes of snake bites, for example, but they do happen, are more common in Highland Scotland and rural England than people would actually consider, because we've only got one poisonous snake in the UK, and that's an adder. But they are much more common than people actually think, and they can cause very nasty side effects. I think the last fatality, to be fair, was about 100 years ago, but they still can cause very nasty side effects. Very, very fast heart rate, huge edema, swelling to the area that's affected, and the whole of that limb. But it's the principle's the same. You've got a bite, get that person to hospital as quickly as possible. In addition to that, you know, if it's a dog or an animal bite, they need to make sure that their tetanus cover is clear, that it's actually quite sound. And it's always a good idea to get possibly prophylactic antibiotics just to keep any possible infection at bay. And we thankfully don't have any risk of rabies yet. Although, mind you, if we're leaving Europe, we're even less likely to rabies, but that's beside the point. So it's always important to know that in any animal bite, generally a doctor's appointment or a hospital appointment as soon as possible is the key thing to get done, because they can infect quite quickly. Okay, right. Diabetes and hypoglycemia. So we're going on to the kind of everyday things that you might come across here. I was called yesterday for a first aid incident for a student who was hyperglycemic. Now, any first aid book that you look at will classify hyperglycemia as a first aid situation. I have to say, I kind of don't, because there's not an awful lot you can do about it. But hypoglycemia, most definitely, certainly is going to be a situation where you need to be called for. So, a hypoglycemic attack, breaking that down again, hypo meaning low, gly is glucose in the EMEA pertaining to the blood, so a low blood sugar. This can happen, to be honest, this will happen to any one of you. This is where you will come into that lovely new word that's been put into the Oxford English Dictionary when you're hangry, your blood sugar's low, and you're feeling a bit hangry. This is what you're thinking about, but with a bit of an added drawback to it as well. So your hypoglycemia in diabetes is caused by the fact that the balance between the insulin that the patient has taken and the food that they've taken has not been accurate enough, or it has not been sustained for long enough, because I don't want to imply that there's a fault to lie with that, because sometimes it just does happen. A diabetic cannot produce generally their own insulin. Something has happened with the islets of Langerhans within the pancreas. They don't produce their own insulin anymore, and therefore they have to take it synthetically, often by injection, sometimes by means of an insulin pump. Now, for the purpose of everything generally here, when we're talking about diabetes, we're referring to type 1 diabetes. The same thing will happen with type 2, but this, for the most part, we're talking about type 1. Type 2 diabetes, in most cases, but not all, is an avoidable situation. It can be treated by lifestyle changes, lifestyle choices, etc., in many cases, but not all. Diabetes type 1 can't. That's it. It's just happened. That's the way it's going to be, and it's going to be a lifelong condition. So the patient with diabetes has to make sure that whatever they're intaking in the way of carbohydrates in particular will balance the amount of food that the amount of insulin that they will need to either inject or have pumped into them, and that needs to be primed on a daily basis. And there's a whole load of really phenomenal research going on just now, even just across the road at the LifeScan, where they're looking at how we might change certain aspects about how people are treated. They might do some gene therapy on certain individuals to try and adjust what might happen with the pancreas, to try and kick-start the Langerhans into producing a bit more insulin. There's a whole load of stuff going on at the moment. It's quite phenomenal what is being done. But in the interim, we still have to fix the person experiencing a hypo. So when that imbalance has occurred and the patient has had more insulin than they have had carbohydrate in that the insulin can act upon, what behaviour, other than being hangry, what other behaviour might somebody with a hypo be displaying?
Aggression.
They could become quite aggressive. Stroppy to begin with, I think, might be fair. Aggressive, I'm absolutely with you on that one, but stroppy to start off with. A bit difficult, you know, just a wee bit stern. Okay, anything else?
Sore head.
They could well have a sore head, yeah. Anyone get anything else to add?
They may appear drunk.
Yeah, they actually look and sort of sometimes display behaviour that makes people think that they're a bit drunk. They can be a wee bit confused, a bit slow in their responses. So while they might not display as somebody who's completely wasted drunk, it is that kind of just getting a bit tipsy, the kind of point where people might just want to go home and go to their beds, that kind of behaviour. Yeah, so really that's what you're looking for. Now, if you know that this person is diabetic, then that's all well and good. If you don't, what might you look for to give you that indication? Can she? Some sort of medical alert again. Something that might tell you this is actually what's wrong with me. That this is the fact that I am a diabetic. Now, to be fair, their diabetes might not be the reason that they're not well. So again, it's important to keep that slightly broad spectrum, that you can only go with what you've been given to work with. It's the same like if you do come across somebody who's drunk, yeah, they might also be hypo. They might be having a stroke. They might be having a whole host of other reasons. Or of what's wrong with them. So it's important that we're clear about how we work on that. So in order to be able to ascertain that, you check maybe to see if there's a bracelet. Ask them, are you a diabetic? If they're not grumpy enough, they might well tell you that yes, they are. That might be a cue to say, well, do you need something to eat? Generally they're going to go, no, I'm absolutely fine, even though they're not. So it's the kind of trick about that is then how you find your way around this, because generally patients who are going hypo are not that easy to work with. You do need to find the skill of working with them, and you might end up having to be a feeder but in order to be a feeder, you have to be able to eat yourself too. So it might be a case of, oh well, here's a bit of Mars bar, then I'm having this bit, and you tear off a tiny corner while you get chowed into the rest of it. But it might be something like that that you have to do. What you do not want is for it to deteriorate further. You need to stop that from worsening. Remember, you're the first aider, you need to prevent worsening of the condition. So you don't want them to start feeling a bit worse. And if their blood sugar continues to deteriorate, they will lose consciousness. They may well start to have convulsions. They may well stop breathing. There's a whole host of things that can go very wrong if that is allowed to continue without being checked. Many diabetics, by no means all, but many of diabetics will carry glucose tablets with them. They're usually just little strips of very, very easily dissolved tablets that they just pop into their mouths, or you can pop one into their mouths. In order for it to dissolve, they then absorb it and their blood sugar starts to come back up again. I say many, but definitely not all. They may carry chocolate on them. It's my kind of diabetic. Chocolate's great because, again, stick a little bit into somebody's mouth, dissolves very fast, high sugar content, absorbed just as quickly. They start to come out of this hypo. The minute they start to become more reasonable, then you can come in with more rugged treatment than just a bit of chocolate or a bit of a glucose tablet. There are any number of things that you can use, but speed is of the essence, of the absolute essence. What I do not want you to try and do at that point where you think somebody is gurney, they're definitely having a lowering of blood sugar, is to give them that is high carbohydrate but low sugar. I don't want you to do that. I want you to give them something that is a quick fix. So, full fat Coke, you know, let's face it, dental therapy students' nightmare. My idea of fun. Full fat Coke, full fat anything, nothing diet. Give them nothing that is 1 cal or low sugar or has anything like sucrose, to be honest, that's just poison anyway. But just don't give them anything that's got anything other than unadulterated, good old granulated white sugar or brown, whichever. Give them that first off. Lucozade is dead easy because it's quickly swallowed and it's quickly absorbed. And it's very, very high sugar. Give them something like glucose, give them something like chocolate. Once they start to pick up, what's your next line of treatment? What would you give them next? You've done the sugary bit.
Glucogel?
Well, it's pretty much the same as giving them the glucose or the Lucozade. The hypogels are very good, they're very handy, in the same as you squeeze them into the side of the mouth, they're absorbed fast. You're going to do just the same thing. What you need to think about here is whatever you've given that patient to take, or whatever you've taken, whether it be your Lucozade, your chocolate, your hypogel, your glucose tablets, whatever it is, they're going to get a nice big rise in sugar. And then what? Given what they've taken, it's just going to go again. That is only sustainable for a very short amount of time. It's the same as any sweetie that you eat. You might think, God, I'm starving, I need a Mars bar, buy a Mars bar, eat it. 40 minutes later you're starving again because it's all gone. You've just burnt it up. There's like a sugar mega rush and now it's gone. So once that has gone up to that point, it's going to plummet again unless you come in with something to balance this off. So what do you want your patient to have, or your casualty to have, after you have managed to get them on the road to recovery with their blood sugar in that immediate phase?
Glucagon.
Same thing again, you're going to get that big spike. What do you need them to do to carry that forward and keep them stable?
Maybe get them to eat something.
Such as?
Like, I don't know, like proper food, not sugar, high content sugar.
You're on exactly the right track. Proper food, whatever mega carbohydrates. A very good quick fix for a diabetic who's at that point of becoming a little bit more reasonable and their blood sugar is beginning to come back up to the normal regions is a banana sandwich. It's just the bee's knees anyway, whether you're diabetic or not. A banana sandwich is a hefty load of carbohydrate. You've got at least 20 grams of carbs in the bread alone. and a good 10 to 15, depending on the size of your banana, of carb in the banana itself. So that is a big hefter. That's, I mean, really, that's about the equivalent of carbohydrate as you would have in a meal. And that's what you want. You need them to get to that level point. That's going to be long-acting carbohydrate. It's not going to give them a zoom of simple sugars and then a crash. It's going to keep it sustained. It's like all those adverts that you watch about breakfast in the morning. You know, if somebody has porridge, it's meant to be that it'll last them significantly longer during the day. No, no, I am starving after 2 hours, but nonetheless, I get the idea. But it does mean that you can get this long drawn out effect of a level blood sugar. The key for a diabetic is keeping their blood sugar as level as possible and as stable as possible. The negative impacts of having a fluctuating blood sugar, whether it be high or low over frequent periods of time, are very negative impacts on the vascular or the strength of the vascular walls. Significant impacts, particularly to the back of the eye. The vessels at the back of the eye are very badly affected by repeated high blood sugars. The vessels in the peripheries of the feet in particular, which is why all diabetics are recommended to use a chiropodist rather than try and maintain their own feet health. So there are definite benefits to having that nice, stable approach to your blood sugar. So, hypoglycemia. Always treat the sugar if you're in any doubt at all. If you think your patient's diabetic, if you suspect that they are hyper, do not be tempted to give your patient insulin. In any case, never ever inject a patient with insulin. If the patient wants to do that for themselves, that's entirely up to them. But it is not your remit as a first aider to do that. Hyperglycemia can be maintained for days and days and days, and in rare situations a patient might become unconscious as a result of it, but it's very unusual that that would happen. So if your patient's diabetic, give them something to eat. Even if they're having a hyperglycemia, if their blood sugar is very high, giving them something else to eat is not going to make that much of a difference if this is an ongoing situation. But you need to be sure that they're not going low, because that's much more critical. Okay? All happy with that? Okay, how are we doing time-wise? Right, we'll just cover a couple of other things. If we go on to head injuries and fractures. We touch on fractures first, because again, that is a fairly straightforward event to deal with, believe it or not, it genuinely is. How many of you with the hands up have ever fractured anything? 1, 2, oh, 3, okay, right. Anything significant that you've fractured?
Just my ankle.
Oh, I bet that was sore though. Okay.
No, I didn't actually feel it.
Oh, good. We weren't asking about the circumstances surrounding the fracture then. Okay, what else?
My head.
Your head.
Yeah.
Oh, lovely.
Yeah.
Great, right, we'll come back to that one too. What did you try?
Your ribs.
That's right. Your ribs, that's right. Okay, no, I have to say, no, I haven't touched anything, I haven't broken anything. My daughter broke my nose. She chipped a bone off my nose. Nothing I could do about that. She chipped the end of the bone by headbutting me when she was 2. I've forgiven her now. Okay, fractures. We'll come back to head and head injury fractures in a little minute. You are very limited of what you can do with anybody being fractured, okay? So don't get too het up about it. First aid courses in the past used to spend days and days and days teaching people how to apply slings and all sorts of fun bandages and all sorts of other things, and really, nah, you don't really need it. Seriously, you don't. If you look in the back of any well-equipped ambulance that is maintained by, that is driven by paramedics, you won't find a sling. Generally, you won't find a bandage either. You just don't, because they don't need them, they don't use them. And neither do you. That's the key thing. There might be situations where you might think that would be useful, but chances are, do you have a bandage on you? I definitely don't. So have a think about that. So fractures generally, the key part is about the immobilisation of the affected part, is about keeping your patient comfortable and getting them the help that they need. So we're ignoring the head because that's about fractures to the skull, and we'll come back to that in a minute because that's really more to do with a head injury. Any spinal injuries we discussed last week, where if you're in any doubt about whether or not somebody's got a spinal injury, you need to keep them absolutely still. Now that's most likely to be like following a road traffic accident or somebody falling from height, or a situation where you just think, actually that patient's lying in a strange position, there might well be a spinal injury there. Then err on the side of caution. Remember, the only time you would move a patient is if you were putting them in more danger, not moving them. Does that make sense? So, if, for example, if a patient's lying beside a wall that's going, oh, 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 seem to be moving on top of them, move them. Doesn't matter what's wrong with them, move them, because they're going to get crushed in this wall anyway. So only move when it's going to make this condition worse if you don't. Fractures to the shoulders, the upper body, the ribs, the arms, the clavicle, the scapula, anything like that at all. Immobilization is the key. Now most people, when they fracture anything in the upper torso, will immobilize themselves. If it's an arm, most people will do that. They will just hold themselves. They will just keep that arm inert. It might drop down, or it might have fallen if they've maybe got a dislocation of the shoulder. Then that's fine, allow that to dislocate, allow that to hang down if it's comfortable for them. Never try and put a patient's limb that's broken or part of their body that's broken into a position that makes it uncomfortable for them. Purely because, remember, I also said it's important to keep your own safety key. If you were going to try and move my massively fractured humerus, I would probably hit you with my good arm, so keep yourself safe, right? So don't try and do that. Keep that patient, as long as they're comfortable, let them do it. If a patient is happy holding a broken arm, why would you then try and move them and say, I'm just going to put this sling on and make them move it up and down and tie it in? No, just leave it. If they can do that, they can do it. If they've got a jacket, zip their jacket up so that they can rest their arm a little bit. If they've got a cardigan, let them zip it up, let it rest. If needs be, if they've got a scarf, tie that around them so it might help them. Don't try and move it unless you absolutely have to. If they're comfortable, leave them. When you get to things like fractures, like we said when you were doing a top-to-toe examination, fractures of the hip, different. If you've heard a cricking, remember we talked about crepitus last week, if you've heard crepitus, leave your patient be, don't move them unless you have to, because getting up and walking is not going to be fun for them, so let them stay flat. Allow the emergency services to be aware of the fact that you suspect a fractured hip there. Lower legs, the lower half of the body is different. A fractured femur, a fractured ankle, a fractured tib and fib is different because the weight-bearing episode is going to be significantly challenged there. No patient is going to want to weight bear. With a fractured femur, they're not likely to be even trying to weight bear, they're just going to be standing, or lying rather, in significant amount of pain. There, all you can do is immobilize. All you can do is keep that limb unmoving. Now, in that situation, some patients find it's much nicer to have their legs splinted. If you've got one broken leg, splint it to the other one, and all you would do there is just tie something soft around the knees and below the knees, just to keep things safely together. That's all you would necessarily have to do. When you've got a large bone fracture, like a femur or like a humerus, what must you also treat your patient for?
Bleeding.
Which would cause what to happen? If they're bleeding internally, what are they also going to develop? Shock. Always, always treat for shock when you've got a large bone break. Your large bones are generally the humerus and the femur. Generally, always. So they're your main areas. Now, if you've got somebody with a fractured femur and really don't want you elevating their leg though, okay, but I do want you to elevate their good leg, you have to do something in order to treat that. If you think of the bone structure, you don't have physio charts in here, you used to have. Anyway, you would have the long leg, you've got all sorts of vessels, all sorts of arteries and veins, and very close proximity around there, lots of soft tissue there to be damaged as well. If you add in addition to that a break, any of these vessels get damaged, you will get localised bleeding anyway. Treat your patient for shock. Keep them warm, keep an eye on their colour, keep them still. With a fractured femur, if their shock develops, they are likely to try and want to get up and walk, and you really don't want that to happen. Your type of fracture is significant. If you have an open fracture, then you've obviously got a significant risk of infection, and that's where the bone has broken through the surface of the skin. So you really need to try and minimise the risk of infection there. Don't ever apply pressure to a fracture, because that's just too sore for words. But if you've got a bone that's protruding, the infection risk is huge. Cover that up, minimise that risk of infection, and do not move your patient again, okay? So that's a very critical part. If you have compound fractures where there's likely to be shattering of the bone, again, it's simply about immobilisation. There's nothing much you can do about that. One of the other reasons that you might notice that a bone might be broken is that, or the signs and the symptoms that you might be aware of, is one of the signs that you might hear is the actual break of the bone itself. So you might hear that. You might hear the two ends of the bone rubbing together, as we discussed earlier, particularly in a long bone. The benefit of that is it means it's quite a stable fracture. The two broken ends are stuck together. You might see misshaping of part of a limb, and that would indicate that the bone has, instead of keeping nice and straight, has done that, and therefore the skin around it has to mould to fit. But nonetheless, your treatment is just the same. What you might also see is a shortening of the limb affected. So regardless of where it is, lower leg, lower arm, upper arm, if the bone has broken and then slightly crossed over on top of itself, that limb will shorten significantly. You might see puckering of the skin, because obviously it's not the same length of skin that's being needed to cover that part of the arm, but you will see it being shortened. That's a particularly specific thing to look out for in the elderly when they are very prone to fracturing the neck of femur. So the neck of femur has broken. Very often the head of the femur will stick in the pelvic cup, but the bone will actually have driven slightly further up, so the limb is much shorter. It can sometimes be up to a couple of inches that you'll notice that there's just something very different going on there with the limb. So immobilisation and get them to hospital. For major breaks and for exposed bones, that would always be a 999 call. For something that is holdable, generally if you take people in the back of a car, I mean I've certainly put people in a taxi with dislocated shoulders. I actually wanted to get them out of the first aid room because they were threatening to fix it themselves, and I'm not allowed to permit that. So I was putting in a taxi over to A&E. He'd fix it. This one guy did actually fix it in the taxi on the way over, but then he gave him a remedy. So things like that could go in a car or as we use as a taxi. But for major breaks, exposed breaks, any particular extensive bleeding, get them into an ambulance as well. So what we'll just touch on just now then is head injury. Okay, so again, we're thinking about the fractures there. We spoke last week about doing a top-to-toe check on somebody, that you would be feeling quickly around the skull. You're feeling for lumps and bumps, but we've all got pretty bumpy skulls. It's a real risk for some people when they decide to go for that full shaved head look, about how they don't know how normally their skulls might look when they expose themselves. But generally people have got quite bumpy heads anyway. But what you're feeling for is something that's just a bit different. You're feeling for that soft bogginess that we described last week, where there might be a compressed fracture. What's your biggest thing that you need to look out for there? What symptoms would you be looking out for with your patient, or what signs would you be looking out for? You've got a compressed fracture where there's a piece of bone being pushed in.
Internal bleeding.
How would that display itself in a skull wound?
Feel quite spongy.
Mm-hmm. What might your patient, what things might you be seeing within your patient though?
Changing colour.
You'd be more likely to see sort of more neurological changes. So you might see a behaviour change, confusion, aggression. It could be anything depending again on where that fracture is, because there's something not right happening to the brain. So if the skull has been broken through, remember last week we said underneath your skull you've got the triple layers of meninges before you've got the brain tissue, and you've got all of that circulating fluid. There's an awful lot of protection there for your brain, for good reason. But if you manage to get through that, the brain is then exposed to some damage. So you might be looking for more neurological signs and symptoms from your patient. Of, as I say, confusion, loss of consciousness, fluctuating consciousness, anything like that at all. Your head injuries, never ever take them too seriously. Never ever take them casually. always recommend that patients go to casualty for a head injury. Never take it lightly. The chances are that they will go in and be seen. The chances are that they may be kept doing it overnight. The possibility is that they may be discharged with a list of head injury instructions, and I don't know if any of you have ever had that experience or seen them. What the casualty staff will do, or what emergency staff will do, is look for what they call the Glasgow Coma Scale. And the Glasgow Coma Scale has been around for decades, absolutely decades, but it's still a very good measure of looking for the physical symptoms of a neurological impact of a head injury. So what you're examining there is the temperature, the pulse and the respirations. Because again, somebody with a head injury will often present with very slow tachypnea, very, very slow bradypnea, sorry, very slow and often gasping breathing. They'll be checking for the pulse, because quite often you will get an increased rate of pulse as a head injury has occurred, but then starts to slow in conjunction with the breathing. And they're also looking for the temperature, because believe it or not, there are certain compressed fractures of the skull will often result in an immediate temperature spike. So it sounds a bit bizarre, because we often associate temperature with infection, and it hasn't necessarily happened there, but because of that neurological symptom. You're also looking in the Glasgow Coma Scale for pupil reaction. Now, as a first aider, you might want to be observing that, but the chances are you're not going to have a torch on you, but you could give it a try anyway. You're looking for pupils that are equal and reacting to light. And be aware that not everybody does have pupils that react to light terribly well. I mean, David Bowie passed away last year. He had one eye that did not react to light. The pupil was fixed and small all the time from birth, I think. My mother actually was exactly the same. One pupil didn't fix. So you need to be aware that that's a possibility, but it's still worth noting. Alright? So the pupils are meant to be equal and reacting to light. And that is only visible by a torch. You would also be looking at the strength that is shown by equal measurement of both legs and both arms. So what you tend to do is ask your patients to squeeze your fingers of each hand. Again, you're looking for equal strength there. There might be something physiologically wrong with the patient that means that they can't, but again, you have to note it. Likewise with the legs. In hospital, you would put your hand up against the sole of the patient's foot and push and ask them to push you away. You're looking for equal reactions to that as well. Okay? Nausea is very common as a result of a head injury. Your patient might feel very sick. They might not be able to see properly. They might have a visual disturbance. They're generally showing the signs and symptoms of a concussion, and that does need to be examined in hospital. As I say, most people tend to be kept in a short stay ward overnight and then let back out, but always with the provision that they have to keep an eye on other signs and symptoms that might go wrong. One other thing that we mentioned last week, which is a sign that you might see, was to do with the meninges. Can you remember what that was?
Clear fluid.
Yeah, the clear fluid that might be coming from the patient's nose or their ear. So again, looking for that. It might be mixed with streaks of blood, it just depends on where the head injury actually might be. Also remember that if a head injury is impacting on the breathing centre, if your patient does stop breathing, you need to be doing CPR. Also bearing in mind that your head injury might actually affect the face. It might be something that has actually been as a result of trauma to the face. Then you need to think about what actually can I do for this patient as far as CPR goes. If you have absolutely no way that you could carry out doing mouth to mouth or mouth to nose, because that is always an option. If you've got significant mouth damage, you might be able to do mouth to nose, which is just as it sounds, okay? You might be able to do the breath that way. If you can't do either of those and your patient stops breathing, it is absolutely sufficient to do pure compressions. And you just keep compressing. If you cannot do any form of putting in an airway or getting some sort of air into your patient. Okay? So that was a quick wrap around head injuries there. Now the three things that we didn't get to cover were epilepsy, sunstroke, and hypothermia. And we also need to just have a quick consideration on major bleeding, but that will just be a simple recap for that, okay? But we can go over these in the next session, which is when? 3 weeks' time? I'm looking to you guys to tell me. It's March something, which isn't much easy, is it? Well, I tell you. And is that a Wednesday? Let me just check. Seeing as none of you have come up with your diary quicker than me. Is it 15? Yeah, you're absolutely right, and it is a Thursday. So, 15th of March, that day, we will finish off the bits and pieces that we need to do, and I will then issue you with your assessment, okay? And again, cannot emphasize enough, it's not hard, you will pass it, seriously, alright? No pressure on you at all. So we will do that on the 15th of March. So we'll finish off the little few bits and pieces that we need to do on the 15th of March, and then I will give you your assessment. And you will have it done in a minute.
What do we need to do to prepare for that exam though? Is there
Read everything that we've discussed. All the notes that you've taken from last week and this week, that's all you need, in all honesty.
Is that available on Blackboard for us?
Is it? No, it's purely the notes that you have here. There's nothing up on Blackboard. The majority of what you've done, the major part that you've already done in your OSCE was your CPR. That's the most significant thing that you need. This is really just the sort of soft bolt-ons around it. The significant part of your OSCE is your CPR. You've already passed all of that. We don't need to go down that route again. All you will be assessed on is the soft stuff here.
Is it like multiple choice or a short answer question or?
Now, you have to remember something from a year ago here. Multiple choice. I'm just visualising it in my head. Yeah, multiple choice.
And I believe last week it's been recorded, but I didn't find it in Blackboard.
Last week may well have been recorded, and unfortunately I've only noticed in one of my emails that there was a request for having it recorded this morning, but I didn't get that till 10:30. There was no point in recording the last hour.
I was absent last week, so I don't have any notes to cover me reading.
But it was recorded. It definitely was recorded. What I would suggest is borrow. Ask your lovely classmates. Give you copies of their notes. All right? They will do that for you. They will absolutely do that. And much the same way, Hanif, I would expect you to do the same for Fiona.
Yeah, definitely, yes.
That's fine. Okay? There is nothing that will trip you up in this assessment. Seriously cannot emphasise it enough. And I'm seriously going to request it to remove the word assessment from that week of your calendar as well, because it just causes all sorts of drama. Okay?
Okay.
Right. Okay, we will see you in a minimum of 3 weeks' time then.
Okay.
And it will be even closer to the holidays. In fact, we'll only have 8 days to go for the holidays now. Won't we? Yes, we will.
8 days.
If I'm, 15, it'll be 10 working days until the holidays when I come back. Okay? What joy. Right, have a lovely weekend when it comes, everybody, and I will see you very soon.
Thank you.
Bye. Bye.